New Nutrition 1. Today we're having presentations on our respective research project, which are looking at the perspectives in the textbook for this course and doing a deep dive into the research that supports that information. Our first presenter will be Sierra Correa, and she will be presenting now.
Okay, so my perspective research project is on the nutritional impact of Roux-en-Y gastric bypass, a surgical approach for the treatment of obesity. So the years 2017 to 2018, U.S. obesity was at 42.4% of the population, and severe obesity was at 9.2%, which if you think about it, that's a really large number. A lot of people are suffering from obesity. So class 1 obesity is defined as a BMI of 30 to 34.9. Class 2 obesity is defined as a BMI of 35 to 39.9. And morbid obesity is defined as a BMI of greater or equal to 40. Some complications of obesity are type 2 diabetes, high blood pressure, heart disease, stroke, metabolic syndrome, fatty liver disease, and some cancers, along with other conditions. Usually obesity is first treated with lifestyle changes like improved diet, increased physical activity, and sometimes pharmacological drugs. But individuals who are obese and meet selected criteria and who are at increased risk for obesity-related mortality can be candidates for bariatric surgeries. So there are several different types of bariatric surgeries, and they usually fall under restrictive or restricted and malabsorptive or just malabsorptive categories. So restrictive, it just makes the stomach size smaller. Examples are vertical sleeve gastrectomy and adjustable gastric banding like the lap band. And ones that are restrictive and malabsorptive, where the stomach is reduced, but it also limits food absorption by bypassing parts of the small intestine, are the Roux-en-Y gastric bypass and the duodenal switch. So our textbook says, and a lot of things that I've looked at, says that the Roux-en-Y is actually the most used bariatric procedure in the United States. But I actually found more recent research, and I don't know exactly what was cause of this switch, but they, the American Society for Metabolic and Bariatric Surgery, which was conducted this year, said that actually in 2019, the sleeve became the most popular at 59.4%. Now, the Roux-en-Y gastric bypass was the second most popular at 17.8%. And out of 256,000 of these surgeries done in the US alone, that still means there was almost 5,000 of these Roux-en-Y gastric bypass surgeries done. And it's still the most successful in terms of weight loss for the patients. So because it's still the most successful, that's the one we're gonna talk about today. So the Roux-en-Y gastric bypass creates weight loss by decreasing food intake, increasing satiety, and decreasing absorption. It creates a small pouch at the top of the stomach, like you can see on the picture. And the path for the ingested food bypasses the rest of the stomach and the duodenum and the first part of the jejunum. So it completely changes the digestive tract for these individuals. Benefits of the Roux-en-Y gastric bypass are patients can lose half to 2/3 of the excess weight within 2 years. It may reverse type 2 diabetes, stop heartburn and reflux. It can lower their risk for high blood pressure, sleep apnea, and for heart problems, among other things. But there definitely are some medical complications that come with this. So bleeding, infection, and blood clots can occur after the surgery. That would probably be a risk with any surgery. Dumping syndrome is very specific to the Roux-en-Y, and basically it's characterized by nausea, vomiting, bloating, diarrhea after eating simple carbs. Stomach stenosis, leaks, dangerous internal hernias, bowel obstructions, gastrointestinal bleeding, and indigestion can also occur. So there also are many nutrition complications. So protein deficiency is very common. Water-soluble vitamin deficiencies like thiamine, vitamin B12, and folate can occur. Fat-soluble vitamin deficiencies like vitamin A and D. Possible fat malabsorption, as well as calcium, iron, zinc, and copper deficiencies. So the causes of these nutritional complications are kind of similar for all of them, but a little bit specific. So, like I said, a lot of people who go under the Roux-en-Y gastric bypass have protein deficiencies afterwards, and that's due to inadequate protein intake, but also reduced gastric acid secretion, which usually facilitates protein denaturization and protein digestion. Also, insufficient amino acid absorption due to the changing of the digestive system and due to just the overall extreme weight loss that comes with the surgery. Thiamine deficiency occurs via excessive or recurrent vomiting and reductions in intake and absorption. Vitamin B12 deficiency is caused by insufficient intrinsic factor, which normally binds to the vitamins in the duodenum to be absorbed later in the ileum, but less intrinsic factor is made after the surgery. Also, with less hydrochloric acid produced in the stomach, it causes the vitamins to not be released as well from the food. And then just overall inadequate intake after surgery. So folate deficiency is inadequate intake and lack of absorption. And fat malabsorption can occur, it doesn't always, but it can occur when the channel below the biliopancreatic and the roux limb opening is too short. And this fat malabsorption can actually cause vitamin A and D deficiencies because they're fat-soluble vitamins. Also insufficient bile and bypassing of much of the jejunum will cause vitamin A and D deficiencies. Calcium deficiency is caused by a less acidic environment for absorption in the small intestine, and it needs adequate vitamin D. So like I said previously, vitamin D sometimes is deficient also, so that'll cause some calcium deficiencies. Iron deficiency occurs because of the less acidic environment for absorption in the small intestine, and also because of the rerouting of the proximal intestine. Inflammation is caused by obesity, can also cause iron deficiency, and meat is not really tolerated well after the surgery, and that's where we get the majority of our iron from. So if you're not able to eat meat with iron in there, it definitely causes inadequate intake. And then zinc and copper, basically deficiencies are from poor intake of the foods that have these minerals and due to less gastric acid in the stomach. So all of these can occur, or just some of these macro and micro deficiencies, and they're very specific with supplementation. So like for example, protein intake should be 1.1 to 1.5 grams per kilogram of ideal body weight after the surgery. Something like vitamin A, you need 5,000 to 25,000 international units a day. And like zinc, you would only need 10 to 40 milligrams a day. Some of the things like vitamin B12 and iron, you actually could be so low that you need an injection or an IV in order to get them up to their normal levels. And this is a great example of why using a registered dietitian nutritionist after surgery is so vital because these things are so specific and you would need a very good plan for your post-operative surgery success. And so they're not always offered. It's something like these people would have to go find, but definitely is needed. So I also wanted to do a little research about additional health consequences post-surgery. So I looked at a few different studies, and this study was the Roux-en-Y gastric bypass surgery, which alters serum metabolites and fatty acids in patients with morbid obesity. Its objective is to evaluate changes in the serum metabolites and fatty acids at 2 weeks and 6 months after the Roux-en-Y gastric bypass. And they concluded that serum non-esterified free fatty acids were significantly reduced at 6 months post-surgery. So this was a smaller study, and they said they needed to have more studies done for it, but it's very suggestive of metabolic improvement. So that's a very positive outcome from people undergoing the Roux-en-Y gastric bypass surgery. Another study I looked at was the effect of Roux-en-Y gastric bypass surgery on diabetes remission and complications in individuals with type 2 diabetes. And the study defined diabetes remission as no glucose lowering drug use with hemoglobin A1C of 48 or metformin monotherapy with a hemoglobin A1C at 42. And basically this was a much larger study. 1,111 individuals with type 2 diabetes who have been treated with the Roux-en-Y gastric bypass were involved, as well as 1,704 matched non-operative individuals with type 2 diabetes. And the conclusion was 3 out of 4 individuals who had type 2 diabetes and were treated with the Roux-en-Y gastric bypass experienced diabetes remission after 1 year. And if you look at the bar graph from the study, the blue are those in remission. So 0 to 6 months, 6 to 12 months later, all the way to years later, there was still a majority of these individuals in diabetes remission. So that is also a very positive outcome from them being able to be successful with their weight loss after the surgery. So another surgery I looked at was longitudinal 5-year evaluation of bone density and microarchitecture after the Roux-en-Y gastric bypass surgery. And it's already a well-known fact that after Roux-en-Y surgery, there is short-term negative skeletal effects. There's been a lot of studies on this. So this particular study was looking at 5 years after. And the conclusion was there is a sustained high turnover of bone loss and bone microarchitecture deterioration occurring in the 5 years post-surgery. So if you look at the graphs, so 0 being like when they had the surgery, you can just see this steady decline of bone mineral density, unfortunately, in the spine, the femoral neck, the hip, all of these places. And so it's definitely something negative that goes with this surgery, but it just shows that if these people prior to going into a Roux-en-Y gastric bypass had a bone mineral density scan to see where they were, and just so they knew that this could be a possibility, so they could make an informed decision: would this surgery be worth it, or could I possibly be one of these people that does experience some decrease in bone mineral density? And then the last study I looked at was guidelines for gastrostomy tube placement and enteral nutrition in patients with severe refractory hypoglycemia after gastric bypass. And this was done at Stanford University Hospital and Clinics. And why it was done is Post-bariatric hypoglycemia affects up to 38% of Roux-en-Y gastric bypass patients, which is a pretty significant number. And this can be, if it's severe enough, they actually usually go back in and do a reversal of the surgery because it's so intense for these people and it's just not good for their health. So they wanted to do this study to see if they could do something else instead of doing a reversal. And they concluded that the G-tube placement can actually occur in the small part of the stomach that's left. And it is a well-tolerated and effective treatment for people with a severe refractory hypoglycemia after the Roux-en-Y gastric bypass, which is great that they've discovered that they can do this. But just for the patients to know that this could be a possibility, because the G-tube must fully replace all oral nutrition to prevent the hypoglycemia. And so that's a big deal that's going to affect their lives quite severely. So it's just another thing for people to be aware of prior to going in for the Roux-en-Y gastric bypass surgery. So the impact of dietitians and the Roux-en-Y surgery or any bariatric surgery is that registered dietitian nutritionists played a major part in pre and post surgery for these patients. They are responsible for their education of their pre-surgery diet because they'd like them to lose some weight and get some of their nutrition levels where they need to be prior to surgery. They also play a huge part in their education of the post-surgery diet, which comes in stages with starting with liquid diets only and then going to soft foods and eventually to normal foods. And like I explained a little earlier, there needs to be a specific plan for their supplementation of their vitamins and minerals because there will be deficiencies of some sort. But after these individuals undergo this surgery, they will come back to be checked on by their doctors, not necessarily follow up with that person, that dietitian. So dietitians, it's really needed for follow-up assessments. I think that I know personally a lot of people who have had some sort of bariatric surgery who have not been successful keeping the weight off. And I think that if they had follow-up appointments with dietitians, it could keep them in line to make sure that they were successful with their weight loss and eating the appropriate amounts of food. And even though they can't eat very much, they're eating nutrient-dense foods that their digestive system can tolerate. So that would definitely be something that would be really good for the patient, and hopefully they give them some way of contacting a dietitian outpatient-wise after their surgeries. And that's it.
Any questions first for Sierra? Anybody?
I've got a couple.
Yes.
Sierra, go back to your early slide where you showed the data, the frequency of the different types of surgeries. It was pretty much near the beginning. And I'm asking this question of everybody. Historically, and even I'm familiar with Hopkins in Baltimore, the Roux-en-Y was done because, as you mentioned, it's very successful for weight loss. However, you have listed numerous complications that can occur. So, does that help explain this new data where the percent of the Roux-en-Y versus the sleeve is changed?
Yes. Yes.
So, what would you think?
Because the sleeve doesn't have as many medical complications, I think that more people are probably choosing to do the sleeve. Yes.
Smell absorbent.
Yeah.
And it's a safer surgery in that respect. And if some of you have worked or will work with pro-life, they of course do a lot of nutrition counseling. But many of the things you list is in reality very true. Morbidly obese, they're going to, and I think you said the research shows they're going to lose more weight probably more quickly with the Roux-en-Y.
Right.
It's considered the more successful, but because of these complications. And they are pretty profound. When you looked at the bone research, which I thought was very fascinating, did they talk about doing any treatment for these individuals, like putting them on osteoporotic medications?
No, they were just looking at, because I think it was more of them looking at their research or statistics over 5 years.
So they weren't looking at treatment options.
Right, they weren't doing treatment. They just wanted to see how their bone mineral density, was years past the surgery.
And when you looked at thiamine in particular, thiamine is found in enriched bread products and in meats, protein foods, which are two foods that are very difficult to eat and are often added very later. And sometimes people, with these surgeries say, I can't even eat bread anymore. I just can't eat it. It just doesn't digest well. And of course, meat can be difficult too, for all the reasons you mentioned. So it's not just eating enough foods, but often they become very selective with the foods they're eating because of being able to digest net impacts. And then my final question was, when you talked about the refractory hypoglycemia, is the G2 placement then considered permanent?
Yes, I believe so. And that's why they were, I was set up like, that's a big deal.
So they don't take it out to see if the person can tolerate it.
It looked like they kept the G2 in there, yeah.
So that's a feeding tube?
Yeah.
Yes.
And the question was, with the surgery, is there enough of a pouch to allow a tube to be used? And does it have to be a J tube? And this has been an ongoing debate with dietetics.
And yeah, so it's great for like us and research wise that they can do that, but I don't know why you want to live like that afterwards,
Well, you make a point about improved metabolic markers, and that reduces risk for what? If you've got improved lipid metabolism, you've increased your risk for what? Chronic diseases. And I've, known patients who said this surgery saved my life, even despite all of the complications. All right, any other questions?
I just had a comment, really interesting about the bone density and also with the emphasis on like supplementing vitamin D, calcium, zinc, and it makes a lot of sense.
And
Now, do you think,
people don't keep up.
do you think there's any relation to, I'm sure there is relation to those deficiencies of calcium, vitamin D, and then those
and if they're like, even if they start, they don't keep up with it, or they like, or you just don't know. If you're not going back to see a dietitian, I feel like these people would have no clue that you're still vitamin deficient in 9 months after, a year and a half after.
Yeah.
So,
And I will tell you, because I work with these patients, I've had patients come to me for their initial, and they don't even know why they're there. They don't even understand, in some cases, the nutritional implications of the surgery.
right.
Oh, why am I seeing a dietitian for the surgery? And I would explain to them, this is the situation.
That's like the question that I kind of talk about is when we talk about it in MNT too, like how the pre-surgery, how it's not more emphasized that this is gonna have to happen after surgery for pretty much every single type of bariatric type of surgery. So it makes sense to be more emphasized in the beginning versus after it's done, because some of them, the complications can change.
Right, and like,
yeah.
so how did they get to you then? Like, were they
Well,
referred?
The program I was working with has an agreement with the bariatric surgeons,
Right.
and they're referred. And they go through a lot of nursing classes. They go through a psychological evaluation. I mean, but obviously nutrition problems got them where they are. So you're starting out with an individual who maybe isn't even that educated or even that aware or even initially concerned.
Right.
So there's so many other aspects.
I have a comment about that. So it's not always required to have a operative nutrition.
Oh, no, it is.
Yeah,
It is.
exactly.
Oh, it is
But
required.
it's not as
It's just not as extensive or effective as
It's also the patient too.
Yeah.
I mean,
lack of
I think the
compliance.
program that I was working with was pretty thorough, but again, the referring physician perhaps is not giving enough information, and because patients come in very confused. But again, it's also the patient, did they listen? You know, are they really afraid about, I mean, there's so many factors, as you know, that can influence somebody's decision and their comprehension and acceptance of the information. But it, you know, it does take a real commitment. And again, like you were saying, Jackie, the patients always appreciate and understand that. Thank you, very good, very thorough, all right.
Role of dietary supplements in sports. A bit of a summary of the perspective. It was by Carson Kohler. Some of the major points were athletes are always looking for a way to get a competitive edge in sports in a legal way, of course. And the supplementation that they go after must have an ergogenic effect, which enhances performance, recovery, or stamina. These are the ones that are sought after by the trainers and the athletes themselves. Most athletes consume a sports supplement of some kind, and almost all of them are either influenced by trainers, teammates, or opponents. He mentions in the perspective it would be a hard task to find an athlete competing in a professional league that doesn't use a supplement of some kind. Some more major points of the perspective. There are only a handful of supplements with proven ergogenic effects. Again, that enhance performance. Some of those being recovery or stamina or muscular strength is also an effect. And it's kind of interesting considering sports supplementation is a multi-billion-dollar industry, or estimated to be a multi-billion-dollar industry. I mean, when you go to GNC or a vitamin shop, you see their shelf and their stock full of stuff, and sometimes it's like, well, what does that even do? So most supplements have insufficient scientific evidence or have an anecdotal report from athletes claiming they have ergogenic effects. Think of just say LeBron James said, I have this vitamin D supplement, and that's what caused me to be so good. Not that he's saying that, but those are some instances of anecdotal reports from athletes. And he emphasized athletes should do research and limit their intake of unproven supplements, and also learn potential side effects of supplements that have proven ergogenic effects. So some of the supplements, a handful of supplements that have proven scientifically proven ergogenic effects are buffering agents, supplements containing nitrate, carbohydrate supplements, caffeine, creatine, and protein. And in this PowerPoint, I kind of focus on creatine and protein the most because I feel as though those are the most popular. So protein supplements, these again have conferred ergogenic effects in athletes. Their effects are increases in overall strength, increase in muscle size, and muscle repair. Most athletes use it for the muscle repair itself. And it's not that different than obtaining protein from the diet. It's just supplementing protein. Think of like a whey protein powder. You don't necessarily, it's like a meal replacement kind of, to just get that extra 25 to 30 grams of protein. So this is a scientific study that I used to kind of take a snapshot. Whey protein supplementation enhances whole body protein metabolism and performance recovery after resistance exercise, double-blind crossover study. So the study aimed to determine if whey protein ingestion enhances whole body net protein balance and recovery of exercise performance during overnight 10-hour and 24-hour recovery after a whole body resistance exercise and training event. Double-blind crossover design, 12 trained men perform resistance training after consuming either a 25-gram protein supplement or a placebo in the evening and again that following morning. The results showed that the placebo group had less exercise performance recovery when compared to the protein group. And they demonstrated that by doing 10 reps that first day, taking the supplement the next day, and then were they able to do those 10 reps again, or were they able to do more? And the protein group was able to consistently perform those tasks, that 10 rep range. And that kind of shows the performance target. And the reason I used this one is this takes kind of a snapshot of all the studies that have been done on whey protein, protein and recovery. So this is that's the reason I use this particular study. And the other one with confirmed ergogenic effects in athletes is creatine. It's associated with increased contractile performance, increased growth, which is hypertrophy. Very popular among strength athletes and weightlifters. And kind of not anecdote, but quotes from them. It's like ability to break through your previous limitations and go through the burn. I don't know if anyone's taking creatine, but when you're doing, I think of something like bicep curls, you're able to like just keep going, whereas before without taking it, you feel as though you gotta stop it. The burn, the pain is too much. So this is a study looking at the effects of 4-week creatine supplementation combined with complex training on muscle damage and sport performance. So the aim of this study was to evaluate 4-week complex training combined with creatine supplementation performance and muscle damage, double-blind, randomized, matched pairing system. Divided the 30 athletes into a placebo and creatine group. First 6 days, 20 grams of either the placebo or the supplement were given, and then following that, only 2 grams of placebo and supplement were given until the end of the study. Baseline 1 rep max squat and body composition, 30-meter sprint, and jump performance were examined on the 7th day and then 2 days before the end of the experiment. And those were how they factored muscle damage and sport performance. So the results of this experiment showed that all 4 tests, both placebo and creatine groups, showed improvement. Sprints and body composition had no significant difference between the placebo and the creatine group. The 1 rep squat showed a 33% increase in strength in the creatine group and only a 25.8% increase in strength in the placebo group. So clearly creatine had a higher increase in strength compared to placebo, and muscle damage was also lower in the creatine group. And this is the data chart, so you can kind of see the ranges, even for body fat. You can see that body fat percentage goes down in the creatine group, those 2 numbers, and in the placebo group. And the main one, the squat, you can see the ranges here, pre-test. And then post-training with the creatine group, that's the 33% increase, so it's a huge number jump, showing the effects of creatine. And again, I chose this study in particular because it's indicative of most of the research that has been done on creatine. So there are, as I mentioned in the perspective, Kohler talks about how there are many supplements that have alleged ergogenic effects or not enough scientific research to claim ergogenic effects. One of them is beta-hydroxy beta-methylbutyrate, which is a mouthful, so I'm just going to call it HMB. So HMB claims to increase muscular strength, increase lean body mass, while decreasing fat mass in combination with resistance training. So many studies have been done on this, and it's not 50-50, but there's so many mixed results. That's why it hasn't been given claims of having an ergogenic effect. Again, some claim there are effects, some claim there are no effects. So this is one study in particular, effects of 9 weeks of HMB supplementation on strength and body composition in resistance trained men. The random double-blind controlled trial, the treatment group received 3 grams of HMB a day, placebo was cornstarch. baseline strength and body composition was taken 1 week prior to supplementation, which occurred at week 2, along with resistance training 3 times a week through the entire process. The tests were 1 rep max on bench press, preacher curl, and leg extension. So results showed there was only a significant increase in strength in the leg extension, and other tests were trivial. Again, this is the data sheet. So if the p-value is less than or equal to 0.05, they considered it significant. So as you can see, the leg extension was the only one with that p-value. So that is what they considered significant. All the other ones were insignificant because of the high value. And again, I chose this study because it is a good snapshot of the many other studies that have been looked at with the potential ergogenic effects of HMB. Again, it's very mixed, so again, that's why I picked this one, because it helped one, but why would it not help the others? Another alleged one is correctin. It's more known for being a flavonoid, which act as antioxidant, anti-inflammatories, and anti-cancer. It is popular in cycling and swimming because it claims to increase VO2 max, which in layman's terms is the body's ability to use oxygen efficiently. So the higher one's VO2 max is, the better they can perform endurance-based tasks, which is why it's popular in endurance sports such as cycling and swimming. So this is a study. Correctin supplementation does not attenuate exercise performance and body composition in female swimmers. They probably named this one after they did the study. So the aim of the study was obviously to evaluate VO2 max with correctin supplementation. It was non-random, convenient sampling. They were all volunteers. 26 female swimmers either received 1,000 milligrams of dextrose, which was the placebo, or 1,000 milligrams of correctin for 8 weeks straight. Looked at VO2 max, time to exhaustion, body fat, and lactate levels, and no significant changes occurred in any of the tests. Here's the data tables, and again, that p-value needs to be less than 0.05. As you can see, it's higher than every single one, and the one we were looking at, VO2 max is too high as well, so that's why there's no claimed VO2 max effects. So, potential research into what could be coming out. I saw this video a couple months back on TikTok of a high school athlete, and he's pretty strong, and they had just won like 5 games in a row, and he claimed it to be because he was taking ashwagandha. He was a running back. He claimed to break all his records because he was taking ashwagandha. So it was like, I started researching it back then, so that's why I brought it up now. It is a plant. It's also known as Lithania somnifera. Suggested ergogenic effect on VO2 max and endurance. So there's a study done, effects of 8 weeks supplementation of ashwagandha on cardiorespiratory and endurance athletes and elite Indian cyclists. So obviously, the study was done to receive the effects of ashwagandha on cardiorespiratory endurance capacity, that is the aerobic capacity of the elite Indian cyclists. So 2 groups either received placebo or 500 milligrams of the aqueous root ashwagandha twice daily for 8 weeks. Measured VO2 max, time to exhaustion, which were tested on a treadmill using a graded exercise test. Results showed a 13% increase in the cyclist's VO2 max scores post-test, which increased about 46 milliliters to 52 milliliters. The placebo group did not experience any significant increase at all, and males reacted more positively than females. there are 5 other studies that look specifically at effects on VO2 max, and they all show similar results. But obviously, 5 studies isn't enough to confirm ergogenic effects, so more research needs to be done. So, how does sport supplementation affect an RD? An RD would need to know about supplementation, even if the patient client isn't an athlete. Anything that affects the diet, obviously, an RD would need to know about. So, for instance, if an athlete comes in and they mention the fact that they are taking a protein supplement, like a whey supplement, whey powder, you would need to get with them and calculate their protein needs, make sure they're not exceeding or they're under their protein needs, depending on what they need to do with their sport or what they want to do with their sport. And you need to figure out is it potentially affecting absorption or digestion of other nutrients. One of them is caffeine, which is a diuretic, so that can affect the absorption of B vitamins, similar vitamins and minerals like that. And you also need to stay up on research data on ergogenetic supplements and their potential effects. You don't want someone coming in and asking a question that you don't have answers to, so it's always good to be up to date on research.
Great. Thank you, Paul. Any questions for Paul on this presentation?
It's interesting about the ashwagandha. I take ashwagandha every day.
They're often it's used as a sleep aid.
And it's
Go up,
for brain activity and
Yeah, and of course, it's Indian herb, so it doesn't surprise me this was done with Indian cyclists. Go to your first slide about your research, the title.
The first one
Yeah,
about protein.
yes, please. What is significant about this study that Paul has chosen? What do you know in terms of research?
How short of a period of time it was?
it's
Look
all
at the-
trained.
I'm sorry, look at the title. I'm sorry, look at the title.
Whole body protein metabolism.
The very last phrase, after the colon.
Double blind.
Crossover study. This is one of the gold standards. In other words, the technique that was used to implement and perform this study is one that should give you valid results. And if you were trying to rate and do a meta-analysis of different studies, you would be looking at the research technique and the strategies. And so, when you're looking at a double blind, which means neither the researcher nor the participant knows what they're getting, crossover, you have a washout period to see if there's anything that spurious or could be affecting the results. And so, this kind of a design is purposely done to try to get as reproducible and as reliable as they can results. So I thought that was important. And as you said, it's sort of representative of a lot of the studies that
All the studies I picked were kind of a snapshot or
Right.
very indicative of what most of the research says.
which is good. And I think that was appropriate for this. And of course, why is whey often chosen as a supplement, a protein supplement?
I believe it's the cheapest.
Anything else?
Is it like the easiest digestible?
Right, I mean, breast milk is predominantly whey versus casein. It gives a very soft curd, it's easy to digest, it's a fast protein, remember, versus a slow protein, which is casein, and, your athlete would want them more fast, which means it metabolizes faster, it's used more quickly in the body. And then it's interesting, HMB, and I'm not sure if it's true anymore, but HMB has been a part of a lot of protein supplements for nutrition therapy you see. And I don't know if they're still doing that, but that I think is interesting. Say HMB on it. And
I did, in my paper, I included it. They are using HMB for treatment in elderly patients with sarcopenia with resistance training. So I saw that.
right, and so you still see that. Who knows? Well, very good. Well, thank you. All right.
My perspective was on chapter 8, and it had to do with eating disorders. So the topics that were discussed in this perspective it went through the basic types of eating disorders that we mostly know about, or we think we know about. So there's anorexia nervosa, bulimia nervosa, binge eating disorder, and eating disorders not otherwise specified. In the perspective, it also touched on the subject of female athlete triad, which is a multitude of just things that happen usually in the population of female athletes. And then other topics that I added to discuss as well would be another eating disorder that's avoidant restrictive food intake disorder, and then the relationship of diabetes and eating disorders, as well as bulimia. I'll go more into that later. So these are just some statistics on eating disorders. So national surveys estimate that they affect over 30 million people, and then 10 to 15% being male. That fact is important just because though it's not as large, it is a large population, but the percentage-wise of people who actually do qualify for these eating disorders, isn't, I would say, as high as common as other disorders. But this fact was interesting that I thought was just good to point out that children as young as 9 years of age have been reporting curtailing their food intake to avoid becoming fat. So that's important just because, younger and younger that kids are being exposed to, social media or just being exposed to any type of diet from their family, just influences everywhere. And it's just really important to know just how young that can really affect kids. There was a study that found that 35% of female and 10% of male college athletes were at risk for anorexia, and then 58% of female and 38% of male athletes were at risk for bulimia. So those numbers are pretty high in relation to once you actually have eating disorders. So I thought that was important to point out. And then so the DSM-5 outlines all of the exact criteria that someone needs to meet in order to be qualified for an eating disorder. So that is commonly referred, and it goes, there's more eating disorders than the ones that I'm going to cover in the DSM-5, but I'm mainly focused on the ones that are in the perspective. Okay, so this is just kind of an overview of anorexia. So it's usually refusal or fear of gaining weight, and that's where the point of obsessiveness comes with the disease, specifically for anorexia. So usually they're severely underweight and don't really see the problem, with their status. So that's why, the overriding goal is to lose weight, even though they already are at that point of underweight status. This is something that I tried to highlight between anorexia and bulimia, is that there are restrictive types and binge purge types in anorexia. So it's not just in bulimia, which before I did these studies, I didn't necessarily realize that those types of actions could also be included for anorexia as well. So the restrictive type doesn't do any binge purging, but or using laxatives, diuretics to curtail their eating behaviors, and then the binge purge type regularly does these things. So I just thought that was important to point out, just because it can have the binging and purging types of activities in anorexia, when you typically just think of it as completely restrictive, or at least additive before it is restrictive. So some diagnostic criteria, which would be in the DSM-5, which is specific for to be qualified for the eating disorder. So weight loss, so less than 85% of that expected body weight that they're supposed to be at, or height and range and stuff like that. I had said before about the denial of the seriousness and health complications of the current body weight, so it's kind of just not really seeing a problem that's as big of a problem. And then also, I don't know if I'm saying this right, amenorrhea, which is just the absence of at least 3 consecutive menstrual cycles, which can affect other parts of the body. And I'll talk about that a little later. And then some statistics. So anorexia is, it does have the highest mortality rate among all the eating disorders, and it's left untreated. Up to 1/5 of people will die despite the treatment of eating disorder-related complications or suicide. So I thought that was important to point out that out of all the eating disorders discussed, that it has high mortality rates. Okay, so for bulimia, generally their normal weight, you wouldn't necessarily look at someone and know that they might have it unless you knew the specific characteristics, and this is compared to the other eating disorders. And you want to basically eat food without gaining weight, which is, obviously the ideal, what everyone kind of wants, but that's really the overriding, the overriding feeling. Control is another big thing, so it's having that control and then losing that feeling of control, so it's like a lap, it's both. So for the control, there's compensatory behaviors that are used in bulimia that kind of cause this cycle to happen over and over again. So it's restrictive, similar to anorexia, and then there's binging, and then it's has effects of feelings of guilt that lead back to the restricting. So it is a cycle. And there is also 2 different types. So the purging type regularly vomits, uses laxatives, diuretics, or the non-purging type uses the compensatory behavior like fasting, excessive exercise. It does not use laxatives or diuretics, or doesn't vomit. So, like I said, when I was talking about anorexia, I was kind of, as I was looking at the different research, I was kind of trying to figure out, they both sound similar, they don't have specific, they have overlapping qualities. So I just thought that was interesting that they both have, restrictive type purging, that they both have these qualities. It's just kind of in the amount that they are specific for certain diagnostic criteria. So for bulimia, there's binging, so eating larger amount of food that would be normal than expected within 2-hour period. And then there is, like I said, about lack of control, feeling that within an episode. So as I talked about the diagnostic criteria, this is just important to keep in mind because as I'll talk about in future slides, if they don't meet all of this criteria, they will then be in a different category of an eating disorder. So that's why it says, the behavior has to occur at least twice a week for 3 months, and it doesn't occur exclusively during episodes of anorexia. So it's important to keep in mind that there's the similarities between the 2. Okay, so this, I'm just going to be talking about anorexia and bulimia. It's kind of just what I talked about, how they're similar, so the treatments have some overlapping things, but they're different because of the root cause. So both involve a team approach of physicians, dietitians, nurses, psychologists. So this is a psychiatric disorder. but it does have nutritional implications. So it's important to keep in mind as well that psychologists and psychiatrists are not going to be the main person, but it's a psychiatric disorder essentially that has nutritional implications. Let's see, so it can be inpatient or outpatient. Really, it's individualized to the patient, their severity of disease. And then, like I said, since it's psychiatric, there's mental state, like making sure, checking to see where someone is at that. So anthropometrics, so, the height, weight, food intake, the length of time they've been dealing with these issues. Rate of weight loss is another big one just because it can put someone in criteria to have an eating disorder or not. Support systems and then other medical conditions that can affect, their recovery. So for anorexia, recovery rates 40 to 50% recover, 30% improve their risk for the nutrition complications, and 20 to 25% continue to struggle, and 10 to 15% die from complications. That, though the 10 to 15% die from complications seems high, it's over, I believe there was a study that said it was something after like 10 years after diagnosis or treatment, or 30 years after. So that number, I believe it seems a little bit high just for diagnosis, but it's over time. And then, let's see, so for bulimia, like I said, it's also multidisciplinary. And then the goals for bulimia are different as they're focused on behavior changes versus like maintaining weight versus gaining the weight. And then in anorexia, at first it's about not losing weight, if that makes sense. And then eliminating the habits for the core issues to actually help the patient recover. Let's see, over 50% fully recover and mostly have good outcomes for bulimia, and then fewer than 10% have negative outcomes for that. So another eating disorder that is talked about in the perspective is binge eating disorder. So it is a provisional disorder that doesn't include the compensatory or purging effects as anorexia or bulimia. It's more emotionally tied and does have feelings of guilt or disgust after episodes. So it's generally, I would say, more secretive, I guess, even though the other ones are secretive as well. But since it doesn't have those more outward signs, there's feelings of guilt. So binge episodes occur where, like in bulimia, there's significantly more food in a short amount of time, and it's usually quicker than normal expectancy of how much you would eat in a period of time, and especially when the patient is not hungry. So it's kind of just extra calories, extra intake. That in the last part, it just says it's generally overweight. So most patients seek treatment for that, for obesity and those-related diseases. And then the diagnostic criteria would be binge eating at least twice a week for at least 6 months, no compensatory behaviors, and it's not associated with purging. So after the binges happen, there's nothing that happens in that aspect of purging, and then it's high amounts of energy dense foods. These are other ones that are on the DSM-5 that the perspective did talk about. So the eating disorder not otherwise specified is now categorized as other specified feeding or eating disorders. This was previously talked about as, like a catch-all for the rest of the eating disorders that, doesn't meet criteria for a specific category of eating disorders, which is why I was talking about the specific criteria, because someone can, for example, have all of the symptoms or the signs and behaviors of anorexia, but they're within a normal weight. So their weight loss is not as significant, even though it can be a good amount. It's not putting them in an underweight status. Another example would be, like I was talking about, anorexia with regular menstrual cycles. So someone could have all of those criteria, but still have regular menstrual cycles, so they're not eligible to use that diagnostic. So frequency or infrequency of episodes. So like I mentioned with the other ones, the time frame of, within X amount of weeks or X amount of months for binge or purging activities. If they don't meet that specific criteria, it's a little bit longer. They still do that. It could fall under the other specified eating disorders. And then with those, from what I looked up, they have just as serious of complications as other eating disorders in other categories. It's kind of thought as, like I said, like a catch-all that's just going to be the other ones that don't fit the specific criteria. So there's another one that is not in the perspective, but I just wanted to also talk about, was avoidant restrictive food intake disorder. And this one is similar to anorexia, but it does not involve like the stress about body shape or like fatness as anorexia does. And it does involve like limitations in strict amount of certain food types. In that aspect, it's similar. So it's diagnosed when there is eating that's manifested by they're not able to meet the energy needs, which is not associated with available food or their culture. It's more like a choice that they are specifically wanting to not eat their recommended amount. And then it doesn't occur with anorexia or bulimia, and it's not associated with the body weight or shape. And then it's also not attributed to a medical condition that would require them to restrict or have a type of energy restriction or anything like that. This was also covered in the perspective. So the female athlete triad, it's a combination of disordered eating patterns, and then the loss of menstrual cycles, and osteopenia, which has nutrition implications, which they have to do with each other, the menstrual cycle and osteopenia with calcium absorption. It's not considered an eating disorder in the DSM-5, but it has eating patterns that do lead to like health effects, and it's also in female athletes and younger women who are, at a time where it's stressful. There's a lot of other factors that go into it, so it leads to how the body is able to use the nutrients, and then it's obviously unique to athletes. That's why it's named that. But it's high stress, energy restriction. You think of, athletes that their body shape really does differences in their performance, so they're more susceptible to disordered eating patterns that lead to like nutrition implications. So though all female athletes are considered at risk, most are long distance runners, figure skaters, gymnasts, ballet dancers, swimmers, just really the athletes that, the body shape is really kind of emphasized and is in the culture of it. Okay, so another thing that I wanted to that's not in the perspective that I wanted to touch on was diabetes and eating disorders, specifically an instance where it's like restricting insulin to be able to lose weight, and that obviously has bad health effects. Considering if you have diabetes, you need your insulin, so not administering insulin has negative effects. So recognizing the prevalence is important because these disease states do overlap, and we, as nutrition professionals, always think about malnutrition, and the implications of patients who would be more at risk because they do have the unique, they're in a unique position to, administer or not administer their own drugs to themselves. So, let's see. So, like I said, it's where individuals who have diabetes can lose or gain weight via not their food intake, plus they have a medicinal restriction that can influence that as well. So the study I looked at, it was on diabetes and eating disorders and manipulation of diabulimia. It was a qualitative research design. It consisted of 55 individuals, but I believe it ended up being 45 participants because of paperwork or something like not filling out the full questionnaire. So it was kind of just a questionnaire of why, how often this happens. And then it was used in patients that have a history of insulin misuse for the purpose of weight loss. So kind of just a study that I thought was interesting because it just showed the prevalence of this behavior still happening if someone had a history. So it's designed because social desirability pressures influence participants to underreport insulin restriction. So this study was just shown to break down just how much that is happening in a population as someone with type 1 diabetes. So in the final sample, 38% stated they manipulated their insulin often. 33% did not do that anymore. 27% said sometimes, and 2% said rarely. So this shows that even though someone might categorize it as sometimes or not anymore, that means that they used to, manipulate this often, and then rarely, that could mean they still do sometimes. So I just thought it was very interesting in just seeing, how much this can actually affect people with type 1 diabetes. And then the age ranges, so I thought it was interesting that the age ranges were from 15 to 58, so it's not necessarily just the younger population. I believe I read something that said it was over the age of 50, there was some percentage that did misuse their insulin for that reason as well. So it's not just younger kids or younger people who just, were diagnosed, or the people who you would think would be typical trying to maintain their weight or lose weight by doing this. 35 of the 45 participants stated that weight loss was the main reason they restricted it, and 87% of individuals were aware of the serious consequences but chose to continue restricting insulin. Let's see. So this is just continued. So it's, like I said, it's just eating disorder with people with type 1 diabetes, and results in weight loss, not acknowledged as a formal diagnosis, but I believe there should be more studies in, obviously, with bigger populations as well. And then it has serious consequences, just as we know with diabetes, whether there's an eating disorder or not, how important it is. So it just shows that, as nutrition professionals, to be aware that that is even a thing. I honestly wasn't aware of that before I did research on it. So I just thought that was a good thing to touch on. And then, like I just said, the serious consequences is that as nutrition professionals, it's good to be aware of this disorder as well as other eating disorders that are out there.
Yes. Any questions? With the diabulimia, of course, insulin is a fat-storing hormone, which is what they understand. And of course, that's all. Do you think that is sort of triggered then some of the research now using multiple drugs to try to manage blood sugars in both type 1 and type 2 to mitigate some of the weight gain that might be experienced, and of course also facilitate better blood sugar control?
Yeah, the studies that I looked at didn't necessarily talk about other ways to, like obviously diet has an influence on it as well. So the study that I looked at didn't really go into that as much, but it's definitely important because it is such a, someone self-administering this after they ate X amount, so it's very much kind of, it's not subjective, but someone can, restrict it just a little bit or restrict it completely. So it has a lot of variables. So
And we're not even talking now about the cost of insulin just skyrocketing and the impact that's having, but of course with more precise using meters and of course being able to have continuous glucose monitoring, we're going to hopefully be better at managing the blood sugar which can then impact positively.
Yeah, in the one study it was awful to see that people reported they were like, I hated myself after my diabetes diagnosis, or I gained weight, so I wanted this at a young age. So it's just, I thought that was
All right, well thank you, and we will meet again.